Hello everyone, welcome to our video course AI for Healthcare Experts about artificial intelligence and machine learning for nurses, medical doctors and clinical researchers. Um, this episode will be about bias in medical AI, so very buzzword in many hospitals. So is your model biased? Do you mitigate bias? How you mitigate bias? So these questions, if you want to introduce AI to any institution, that's question you will be asked like multiple times. So I assume it's valuable to understand what is bias in AI, why does it happen, and how to mitigate it. So why bias happens in AI models? The main reason is that AI learns from data. We discuss it, and we have special video about how AI sees the patient, like through data, and why it can be not optimal, but we don't have another choice. So the point is, we have patient, we have some clinical reality with physiology, symptom, with some history, with some disease, and we have some measurable things like images, sensor data, some clinical notes, codes in EHR. We have some diagnosis, and some waveforms from measurement. But we have also some missing data. We have some notes that not fully represent clinical reality, and the model is trained not on reality but on this fragment, some data footprint. And they are not perfect, obviously, and sometimes they are systematically imperfect. So that is significant. So what does it mean? For example, we have some two different types of chest X-ray, and in some high risk environment, like in intensive care, with like for patient with respiratory disease, we use like portable some scanner or portable ultrasound that provides some specific resolution of data, for example, or some specific markers that makes it obvious that this source of this image is this portable scanner. And if in this environment prevalence of pneumonia much higher, that is obvious. If it's like ICU for patients with respiratory failure, like pneumonia will be higher there. Then model can train not on some opacity in the lungs, but it can train on the fact that this comes from this specific scanner. So it will, at once it sees that this is scanner, this portable, then it will say that this is disease. And if not, it will say, okay, patient is healthy because it's another scanner. So, and in my previous data set, when patient were from different scanner, like they were healthy. So model can train not on something that we think it should train, like on opacity, but on, for example, resolution of the image. So it can train on different features that we expect. And this is called shortcut. So one of the most famous shortcut is when researchers wanted to train car to drive with autopilot. They trained it to, like, they make penalty if the car crash into something, and model trained to drive like backward because there was no sensor that it crashed on the back, and there was no penalty for this. So model achieved very high result in the environment during training, but it didn't have any sense. And this possible also during this training. So model can take into account something unmeaningful and unreliable and senseless regarding data source. Another point, for example, a good model will train on real physiology like pressure, some blood analysis, but we also, when we show this information to data, to model knows, for example, frequency of how often this lab ordered, or frequency of lab results, or some specific nurse notes. And if in the hospital, for example, for more ill patients, the labs ordered more frequently, then model will consider that if there are more results, then patient is sicker, and if there are no results, then patient is healthy. So new patient that come without any results and like there was not for them, they will be considered as healthy just because retrospectively in historical data, patient with less lab analysis, they were healthier. So this is something that also important to keep in mind, and that's also can lead to bias. So not physiological data, not physiological features relevant to some specific clinical workflow. The same with devices. So we have some measure. We can have one measure, but different devices can measure it a little bit different. And if we always measured with this device and then we change it, or in another hospital we use another device, so model performance will be worse, because like real value 89, we train that it's like, for example, 90. Okay, 92 it's bad device, but or for example we took into account like average value, so, and this is more accurate. So it was 90 and here it was like 88. And if device changed, or another hospital another device, so results may be a little bit different. So that's also one of the source of the bias. So this is what we talk about frequency of the records. So for example here patient unstable, so we have vital signs measurements each 15 minutes. We have a lot of lab results, a lot of nodes, and because patient was unstable, obviously, so it required constant attention. And patient that was stable, we have just few measurements and like one node, and model think that it's low risk, but it was trained specifically because all unstable patient had more measurements. And if we will ignore record density, so actually risk for this patient is higher and for this patient is lower, because in reality actually it doesn't matter how many results, how many times we take results. It's important, it can be just because we get cheaper lab results, so we changed our procedure. Important what kind of result do we have. And if model was trained more results worse, then it will be biased because of the protocol, and that's also should be taken into account and should be mitigated with this. So how mitigation happens? We should take different hospitals, different workflows. We should not put into the model a lot of things that are relevant only to specific workflow. At least we should make it consciously, so we should understand why we do this. We should like test on different subgroups, different population, different diagnosis, etc. We should be sure that performance is well on subgroups, and it has some meaningful outcome. So always close collaboration between clinicians and data scientists. It should happen all the time. Before deployment, of course, it should be some kind of validation, comparing of workflow, like are we sure that nothing changed, how closely we integrate it into the workflow. And after deployment, of course, we should track metrics. There is special episode regarding drift, but bias is also important. So it's things very related to each other, because drift happens because of initial bias. So it's something that we need to track, and if needed, uptrain model or change threshold or change protocol how we react on model performance. So this is a really important and interesting topic. This is one of the most difficult things to build unbiased model, and that's the reason why we need more and more open source dataset and more opportunity to work with data from different facilities. That's the reason why data from one hospital will never be reliably scalable and generalizable, like across even the region. So we need more collaboration between different hospitals, different level of hospitals, between countries. Then we will be able to build reliable, unbiased model that will really help to improve healthcare. Follow us on YouTube, follow us on LinkedIn, ask questions, click like, subscribe, and ask questions. We will be happy to answer to make AI easy to understand, predictable, and usable and helpful.